will be posted on the Renal website. So with that, let's get started with the next slide. So we'd like to acknowledge that the land on which we host this session is on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And wherever you are in this province or in this country or any other country, to acknowledge the spaces and places and the people that have come before us. And in the spirit of peace and reconciliation, commit to learning more and understanding more. And it's interesting, where close to where I live, which is Kingsway, is an old bear and fishing trail, which actually has different names depending on the reason. Kingsway, for those who live in Vancouver, goes not straight, as in it cross cuts, is because it actually used to follow a stream that was there, and that's where the bears would catch salmon and eat berries. And so if you learn a little bit about where you live and play, then it becomes all the more interesting. So with that, next slide, please. Province-wide rounds is the collaboration between UBC and British Columbia, the UBC Division of Nephrology and BC Renal. We are indebted to our industry partners and all of you in the health authorities for helping to ensure that we have the most up-to-date and topical things to talk about by excellent speakers from within and outside the division. Next slide. So with that, it really gives me great pleasure to introduce a cast of experts that we're going to learn about vascular access management and looking at current and beyond current practice. But I'm going to introduce everybody together, and then they're going to smoothly give you a presentation that hopefully will stimulate a lot of questions and thoughts. So Dr. Rupert Major is a clinical associate professor in the Department of Population Health Sciences at the University of Leicester. And he has joined us in his interests looking at kidney failure risk equation and its impact on clinical care. He completed a Kidney Research UK funded PhD in relation to cardiovascular disease, risk prediction, and chronic kidney disease, and is a consultant as of 2021. Dr. Merecedeh Kiaii is a consultant nephrologist at St. Paul's Hospital and a clinical associate professor. She's also the medical director of the St. Paul's Hemodialysis Unit and Vascular Access Program, and has been passionate about vascular access and optimizing that in hemodialysis patients forever. Dr. Megan Borkum is a nephrologist originally from South Africa, completed a hypertension fellowship at the University College London, and UBC Advanced Nephrology Training and Home Dialysis Fellowship, and is in her second year of a BC Research Scholarship. Also enrolled in a Master's in Health Administration, and her interests include home dialysis, cardiometabolic disease, and patient-centered care. And last but not least is Dr. Mohammad Atiquzzaman, who we fondly call Atiq. He's a research scientist at BC Renal and an assistant professor in the University Division of Nephrology. He holds a PhD from UBC with a major in pharmacoepidemiology and a research interest in epidemiological questions that have real-life implications in patient care. So with that amazing cast of people, I'm going to turn it over to the team to educate us and stimulate our thoughts around vascular access management. So thanks everybody for joining today, and over to you guys.
Thank you, Dira, for the introduction. Good morning, everyone. I'm very excited to be here today with this amazing group of panelists to discuss vascular access management and going beyond our current practice. And before I start, I do want to thank Alexandra Rahman, who is not speaking, but has been extremely helpful in providing us with the data for the talk today and for the ongoing work that we're doing in this area. Next slide. So in terms of the agenda for today, I'm going to first start by talking a little bit about our BC data, but focusing on incident rates, and then talk about AV fistula creation timing, review our current and the proposed recommendation for not only for referral for assessment for vascular access creation, but also for prioritization for the timing of AVF creation. And then we like to end the talk by discussing a topic that's become an area of interest recently, which is the AVF care in post-transplant patients, outline the controversies around this area, and discuss our planned study that we like to embark on with our colleagues in the UK. Next slide. So everybody knows this, but just very quickly, abbreviation. So VA will refer to vascular access, arterial venous fistula, AVF. So next slide. So in terms of the vascular access data, one of the main questions that we wanted to look at was that for all the patients who do have a fistula created pre-dialysis, how many of them end up never using their fistula and die with a functional fistula? So something that we'd like to improve on. So we actually looked at our data over the last 10 years in BC, and approximately 4,000 fistulas were created. Out of that, 2,500 were created in the pre-dialysis patients, and about 10% of those patients ended up dying without ever using their fistula. So not a huge number, but something that we'd like to improve on. Next slide. So in terms of patients who do start dialysis, we went back over the last year, and about 864 patients in BC had started maintenance dialysis. The incident fistula rate in this group of patients was 16%, which is not great. But then we excluded patients that we really couldn't create a fistula pre-dialysis. So patients who did not choose hemodialysis as their preferred modality. So we focused on patients who were known to nephrologists for more than 6 months, had education about vascular access, so had prior KCC care, and chose hemo as their preferred modality. So if you look in this group of patients, our fistula incident rate was actually pretty good. It was about 40%, close to what targets would say. But still, we had about 127 patients who started with a catheter. So is there something we could do to improve this number? So out of this group, 32 patients were medically deemed not suitable for fistula creation, or they refused. So perhaps in this group of patients, we couldn't create a fistula. But if you look at the rest of them, 43% were never referred for fistula creation. 25% were referred, but late, so fistula was never created. And 33%, the fistula was created, but didn't have time to mature or had primary failure. So again, not enough time to be able to have the patient start with a functional fistula. Next slide. So moving towards AVF creation timing and what our current process is for vascular access referral, I think that probably most centers do refer patients for renal replacement therapy education and modality selection around a GFR of about 20 to 30 mils per minute. And then when patients choose hemo as their chosen modality, then most patients are referred for assessment for vascular access creation around a GFR of 15 to 20. After that, the process differs probably in different centers, but I can tell you that in our center, in our vascular access clinic, we see the patients as a team. So the surgeon, myself, and our vascular access nurse. And we look at the patient overall, how they're doing, their symptoms, how quickly is their eGFR been declining. And if they reach a GFR for around 13 mils per minute, it's not improving, that's when we go forward with referral for creation of the fistula. Next slide. So we all know that recently, though, we have risk prediction tools available to us to help us with our vascular access planning. We've all heard about the kidney failure risk equation. And for this talk, we're going to be focusing on the 4-variable 2-year KFRE. This was introduced initially in 2011. The 4-variable includes in the equation the patient's eGFR, their age, their sex, and the albumin to creatinine ratio. And as everybody's probably aware, there's been a number of studies that have been published looking at using the KFRE for vascular access planning, the most recent one being published in NDT and presented at the EDTA. But we're not going to focus on these papers because we've had amazing work done locally. So I want to now hand the slides over to Atiq, who's going to talk about the local experience and what we've learned. So Atiq, please go ahead.
Thank you. Good morning, everyone. Thank you, Dr. Levin, for the nice introduction, and Merecedeh for the opportunity to talk. So we recently published this article on the role of KFRE in vascular access planning earlier this year. Yeah, next slide, please. As a background, so the eGFR-based prediction for dialysis initiation appeared to perform poorly. So the proportion of patients who started hemodialysis on a working fistula or graft within 6 months to 2 years follow-up period appeared to be varying from 17% to 45% based on the study location and study population. So we hypothesized that KFRE, since it predicts the short-term risk of progressing to kidney failure, if we use the KFRE as an adjunct variable to the existing EGFR-based referral, this could play a better role in vascular access planning. So our objective in this retrospective study was to first describe the real-world vascular access creation and utilization pattern in our province, and we wanted to investigate the possible utility of KFRE as an adjunct variable in vascular access planning. So we conducted a retrospective cohort study using PROMISE data, and we included non-dialysis dependent CKD patient who had eGFR less than 20 ml per minute and chose hemodialysis as their preferred mode of dialysis over a 10-year period. And we categorized exposure into 3 categories because in the published literature, the KFRE greater than 40% has more than 80% sensitivity in progression to kidney failure within a year. So our category of exposure was 3 categories: current EGFR-based referral, and we added KFRE greater than 40% and less than 40%, less than or equal to 40% with the existing referral system. We looked into 2 outcomes. One we called a timely preemptive creation. What we meant by this is patient started hemodialysis on a working fistula or graft within 2 years from the modality selection date, and too early creation, that is a fistula or graft was created, but patient did not start hemodialysis within 2 years. So that basically not desired. So our study cohort included 2,581 patients. Median age of the patients was 71 years. 60% of the study sample was male, and we had a 55% white population, and altogether 32% Asians. Median EGFR at baseline selection, in our case, the index date was the modality selection date, was 14 ml per minute, and patient had moderately increased albuminuria, and the baseline KFRE risk score was 49%. Out of the study, approximately 2,600 study patient, 52% patient, that is 1,347 patients, a fistula graft was created within 2 years. Of the total 1,347, 98% of this vascular access was fistula, and median time to create this fistula from modality selection date was 106 days. So then we looked into real world patient journey, starting from choosing hemodialysis, then if they had a vascular access created, yes or no, and of the patient in whom vascular access was created, if they had started hemodialysis within 2 years, yes, no, or died. So if we look into on the left side of this, so 69% of the patient in whom vascular access created started hemodialysis within 2 years, and in 51% of the patient in whom a vascular access was not created started a hemodialysis within 2 years. So together, 1,562, or that means 61% of the study sample started hemodialysis within 2 years. Of this 1,562, 43% started hemodialysis on a working fistula or graft. And we looked into the median time for HD initiation. In the overall sample level, it was 198 days. And it was substantially different among patients who created AVF and not. So in patient in AVF created, it was 267 days. However, in whom the vascular access was not created, they started hemodialysis much earlier. It was 76 days. So we looked into the key variables, those were associated with the HD initiation. So we're looking into patient here, started hemodialysis 2 years, yes, no. So in whom patient started hemodialysis, the proportion of males were higher, and median EGFR was at G5 category, and KFRE score was almost double in this patient, and patient was albumin was substantially higher in those patients. So this is the utility of KFRE in vascular access planning. Left-hand side panel, when what we see is if we use KFRE as an adjunct variable, the timely preemptive creation appeared to increase from 49% to 58% in KFRE adjunct KFRE group, and too early creation, that is patient created vascular access did not use, appeared to decrease from 31% to 18%. So in summary, what we found that KFRE as an adjunct variable to the existing EGFR-based referral looks like can play a better role in vascular access planning. More patient will start on the working fistula or graft, and fewer patient would have had wait for an extended period of time, and we need future research to validate our findings.
Great, thank you, Atiq, and hopefully some of the research I'm about to present will help to validate those findings you just mentioned. So, good afternoon from me. Good morning to you all. I'm Dr. Rupert Major from University of Leicester in the UK, and we've started to work together on some of the issues around vascular access and particularly cardiovascular risk around ligation. I'm going to present some of our results here. So if just for context, this is where I am at the moment in the UK. So we're around about in the middle. If you know the geography of the UK, we're about 100 kilometers or so east of Birmingham. So Leicester City itself is actually going to be one of the first cities in the UK not to have an ethnic group majority. So we're very ethnically diverse. We're perhaps most famous, and certainly from the university's point of view, for having discovered the remains of Richard III, the king, the last English king to die in battle. And again, as further context, the Leicester network actually covers an area much larger than the city of Leicester. We cover about 2 million people. We have about 1,500 people living with a kidney transplant, and about 1,000 people receiving maintenance dialysis every year. Thank you. Next slide. So again, just to touch on the ethnic diversity of Leicester. So our largest ethnic group is the South Asian ethnic group, and that's predominantly people who can trace their ethnic roots back to India, quite often via Uganda and Idi Amin in the 1970s, who expelled many people of South Asian ethnicity from Uganda, moved to the UK, and many of them found themselves living in Leicester. So those are our roots. More recently, though, we have lots of immigration and particularly asylum seekers coming from areas like Afghanistan, seeking sanctuary in Leicester as a city of refuge. So as part of my PhD, we did a study. Sorry, can you go back one slide? Is that okay? So as part of my PhD, we did a study looking at a primary care CKD population in Leicester, and we did this comparative analysis in MDT, and we found that people of South Asian ethnicity compared to white ethnicity is more likely to be younger, more likely to have advanced CKD, both in terms of a lower EGFR and a higher urine ACR. Therefore, as you'd expect, more likely to progress to end-stage kidney disease, but actually the cardiovascular disease rate when you corrected for age was fairly similar. So that's the background to Leicester. In terms of the UK background, probably fairly similar to the figures you just described for BC as a province, and perhaps for the wider country. But about 17% of people in the UK haven't seen a nephrologist within 90 days of starting dialysis. So this often means, as we see here from the UK-wide data, where TL in the third column with figures on it, it refers to tunneled line. I think we both use the same phrase of permcath, and NTL is non-tunneled line or VASCATH. So as you'll see from that is it's the more time before you see a nephrologist, or the more time you've seen a nephrologist for before you start dialysis, the more likely you are to start with a fistula. And if you've been seen for over a year, again, very similar number to the BC-wide figure of 47% of people in the UK will start on a fistula if they've seen a nephrologist for at least a year. Next slide, please. So the UK, the KFRE in the UK, we studied. I led the research on this as part of my PhD that Adira mentioned at the very beginning, and that led to a recalibration of the KFRE for the UK, and that's a paper published in PLOS Medicine. It subsequently led to a change in the national guidelines, the NICE guidelines for people living with chronic kidney disease, and focused on counselling people about their risk of needing dialysis and using a referral cutoff of more than 5% in 5 years. But those guidelines are very much focused on primary care and the management of CKD, so there was no mention of using the KFRE or EGFR thresholds for vascular access referral. And this recalibration has meant that compared to the non-North American calibrated KFRE, the predicted risk in the UK is lower. And so it's important that we use that when we're studying its actual impact in clinical care in the UK. Next slide, please. I don't think certainly in Leicester, I don't think our pathways for vascular access creation are quite as well developed as the ones you've described. But generally speaking, we start to talk to people about the actual modality that they might want for dialysis and preemptive transplantation once the EGFR is below 20. Again, we're starting to use the KFRE a bit more around that to try and have an earlier discussion if somebody has a higher EGFR but heavy proteinuria. The referral for assessment for vascular access creation, again, we don't have a rigid cutoff. It tends to be less than 15 once we start to think about referring. And equally, there's also, once we've made that decision to proceed with AVF formation, we tend to simultaneously refer for vascular access creation at an EGFR of less than 15 currently. Next slide. So the aim of our study was, again, similar to the work that Atiq has just described, was to try and understand what the impact of different thresholds were in terms of vascular access referral rates using the EPI 2009 EGFR cutoffs that we've described and the UK recalibrated KFRE. Next slide, please. So there are some differences in our studies. We don't have, at present, we don't have research data. We have audit data for the rates of vascular access formation, but we've not got that data included in this research database. But essentially, we have access to an anonymized research database within our renal data system. We looked at all individuals with an EGFR of less than 30 from 2009 up until this year, and we compared the different thresholds of 12, 13, 14, and 15 for EGFR and 20, 30, 40, and 50 for KFRE. And we followed up people until they either met the threshold within 2 years, or we continued until they commenced KRT, died, had their last outpatient appointment known to us, or 2 years had elapsed. So we would censor people when we no longer thought we were reviewing them in outpatients. Next slide. And we looked at a number of different assumptions for the cohort. Because it is an EHR-based data extract, we had to make certain assumptions. The granularity of detail around the patients perhaps wasn't quite as clear as some of the data you've just presented. So we looked at a number of different assumptions, and they are there, that they're shown there on the screen. The data I'm going to present today is in relation to people who were definitively in outpatient departments and seen by a nephrologist and outpatient. But actually, all the findings I'm going to describe held for whichever assumptions we made about this group. Again, what I'm describing here is actually a comparison of the Leicester data versus the BC data that you've just heard about. So again, similarly, we've looked at some slightly different thresholds, but again focused in on that 40% 2-year cutoff. And we've looked at whether preemptive creation of fistula was timely, and the amount of time it the referral would have taken place before it was created, and then referrals per KRT case as well as our other main outcome. As you'll see on the right-hand side, a fairly similar cohort in terms of age, gender split, ethnicity splits as well. As we had a slightly higher extract EGFR, our median EGFR is higher. Levels of proteinuria are fairly similar, but that then impacts on the median KFRE risk as well. Thank you. Next slide. So this is a main summary of our data, and we're still working on it. It has been presented as an oral abstract at a UK conference last week, but not yet been published. But as you'll see from the EGFR threshold cutoff there, if we were to refer people with EGFR less than 15, around about a quarter of those people may actually die before they progress to end-stage kidney disease within 2 years. A third of those people would have progressed within 2 years. And that potentially means we might be needing to refer up to nearly 3 people for every person that progresses. The median time to KRT in that group was around about 300 days or 10 months. And similar again to the BC data, the 10th percentile was about 70 days. In other words, 10% of people who progress to KRT will do that within less than 2 or 3 months of that. So it's perhaps always going to be difficult to pick up every single case of KRT. As you'll see with the comparisons to the KFRE based thresholds, using a 40% threshold meant that a lower percentage of people died within that time. We picked up more cases, and overall the referral number of people we needed to refer to pick up a KRT case was lower. And again, the time to progress to KRT was similar in terms of the median and percentiles for that. And as you might expect, if you have a slightly higher threshold, you pick up more patients, but you may well be missing patients who you don't refer in time. Next slide, please. So the summary of our data is very similar to what's been described for the BC data. So compared to a 15 mil threshold for referral, 40% KFRE threshold would potentially lead to a reduction in referrals. Low numbers of those referrals per KRT case we pick up. In other words, a reduction potentially in the number of people dying with a functioning fistula as well. But equally, there's still a similar amount of time to actually get that fistula done. As we've seen from the BC data, it's around about 100 days needed to try and develop that as well. So next slide, please. So we summarised when we presented this to the UK audience is clearly KFRE may improve referrals, but there's still clinical judgment needed within this, looking at the decline in EGFR rate, looking at other comorbidities for the patient. Is the first fistula likely to be functional, or may they need more than one attempt to create a fistula, to have a functional fistula? All those factors need to be taken into account clinically. And ultimately, and one of the reasons for talking today really is to actually start to think about looking at this at a multi-center level, and whether we can start to develop a collaborative looking specifically at this area using UK multi-center data and Canadian multi-center data. I think it will hopefully get us to a point where we can definitively answer what the best threshold is for referral. So thank you for listening. I'm going to pass on to the next speaker.
Thank you, Root. So moving forward, we've seen how we can sort of use the KFRE to help with vascular access referral planning, but we'd like to actually look at now using the KFRE thresholds to help us decide at what point or which patient should go first in terms of vascular access creation. So we've had the opportunity to look at our current data to start to look at these KFRE thresholds and hope to embark in a future study to further evaluate this. So I'm going to hand this over again to Atiq, who's going to show you what we found so far and what we're planning to do.
Yeah, thanks, Merecedeh. So we wanted to understand what is an optimal KFRE threshold to actually create the vascular access. So if we are referring all the patients with KFRE greater than 40%, if we think about it on a baseline, a patient with a risk of 40% risk of recurring dialysis in 2 years may not need the AVF created immediately. However, if a patient had a 71% risk, it may need faster. So if we go to the next slide, please. So in order to understand the distribution of KFRE in patient in whom who started dialysis within 2 years, so we first have taken this 1,562 patient of the total population of 2,581 patients from our published study, and we created this scattered plot. And what we found is the KFRE's majority of the patient is about above 60 and 60 and above, and the greater the KFRE score, the shorter the time to initiate hemodialysis. So then we went ahead. Next slide, please. So then we stratified this 1,500 patients who started hemodialysis within 2 years and stratified them by their time to initiate hemodialysis. So within 3 months, 3 to 6 months, 6 to 9 months, with a 3 months increment, and from 1 to 2 years. What we found was 47% of the patient started hemodialysis in less than 6 months' time. And in this patient, this around 733 patient, the median KFRE was above 69%. So next slide, please. Then we looked into the data in the other way, that if we had stratified the patient based on their baseline KFRE value, that is the KFRE 2-year risk, 4-variable KFRE 2-year risk on modality selection date, what we found was if we have taken the proportion, the risk greater than 60%, it covers 50% of the patients. So other way, if we say that if we triage patient based on a KFRE of greater than 60%, it will cover 50% of the population. And the majority of this patient started hemodialysis in around, again, 6 months' time. However, in the numbers we have just described, we looked into this distribution of KFRE in patients who started hemodialysis. Since it is the retrospective nature of the analysis, we knew who started hemodialysis. But in terms of real-life application, on the day of modality selection, we will not know if the patient will start hemodialysis in 2 years or not. So then we needed to calculate the positive predictive value of this 60% or higher threshold to see how it works in the overall population. So then we applied that threshold, KFRE threshold, into our total population of 2,581. What we found was as the KFRE increases by increment of 10%, the positive predictive value substantially increases, and it becomes 88% in patient who has a 70% risk, and it was 76% in patient who had 60 to 70% risk. So this is the 2-year outcome. And as a sensitivity analysis, we said, how about we see the patient start hemodialysis within 6 months? And we found a similar trend that the positive predictive value kept increasing as the KFRE increased. So with this in mind, next slide, please. Then we formulate the research question that what is an optimal KFRE score for vascular access creation? We looked into we kind of get a sense with the existing data, but this research question is very similar to the other research question in our kidney world. What is an optimal eGFR for dialysis initiation? And this question, if we go back just one slide, please. This question is very well answered with the IDEAL trial published in New England Journal of Medicine in 2010. And there is a new observational study published by Fu et al. In 2021 in BMJ. If we go to the next slide, please. We'll not discuss about the clinical finding because we know that this study conclusion was very similar to the study concluded the New England Journal of Medicine IDEAL trial. However, we would like to draw attention to this method that this study adopted, the cloning, censoring, and weighing. So although these methods are complex, but this enables us to use to mimic clinical trial design using observational data. So what we thought, we have since we have very rich PROMIS data. We have clinical data for over a long period of time, and we have this method that can mimic clinical trial. We want to use this method to answer our research question using PROMIS data. So if you go next slide, please. So we are proposing two studies to understand the optimal KFRE risk threshold to create vascular access. In the first study, we will conduct a retrospective study using PROMIS data. We'll include all the non-dialysis dependent CKD patients and who chose hemodialysis as their preferred mode of dialysis. And we will create 4 categories of exposure: KFRE less than 40 and 40 to 60%. Here we merged these two cells because 40 to 50 and 50 to 60 had similar proportions. We collapsed it into one category. And then we'll look into the patient started hemodialysis on a working fistula within 6, 9, and 12 months. And once we find out the risk ratio, hazard ratio from this particular answer question, then we will go ahead and want to do a clinical trial on our non-dialysis dependent CKD patient, where health authority or clinic will either randomize to the existing EGFR-based referral or the threshold we found out from the study, and outcome will be the aged initiation on a working fistula in 6 months. So we are currently working on the study 1, and this is our future plan to go ahead. Yeah.
Thank you, Atiq. Yeah, so we're very excited to start to look at this data and plan this very complex next study that we're going to do. So we're going to change gears now and talk about another topic that has become a very topic of interest, which is the AVF care in patients post-transplant. I think we'd probably all agree that right now we don't really have a standardized approach for monitoring and management of these patients' fistulas, and unless there's a problem, they don't really come to light. But the question that has been raised recently is it okay to leave these patients with a fistula for many years, or should these fistulas be ligated? So there's obviously advantages and disadvantages. The advantage would be obviously if these patients develop acute kidney injury or their graft comes to failure, they don't require to have another surgery. They have a functional fistula and they can use it for dialysis. The disadvantages can be anything from patient discomfort, localized complications of the fistula, and the more important cardiovascular implications of having these fistulas. So if we do decide that we should go ahead and ligate, then we have to answer the question, who? Do we ligate it in all the patients, or do we look at only patients with high flow fistulas? And what is the definition of a high flow fistula? Or do we actually look at patients, the previous slide, look at patients and focus on patients who have heart failure symptoms, or do we look at patients who have structural heart disease, so on echo or cardiac MRI? And the next question that we have to answer is when is it safe to do this? 6 months post-transplant, a year, 2 years, 5 years? So we don't know. And so this presents a really difficult clinical dilemma. Next slide. And so what I'd like to actually share with you guys is the difficulty that we have to sort of make a decision clinically when we see these patients with the case that we recently saw in our vascular access clinic. So this gentleman is a 57-year-old male, IgA nephropathy, dyslipidemia, and a history of hypertension. He developed end-stage renal disease, started dialysis with the left forearm fistula in 2005. 4 years later, he had a transplant, did really well, no issues with his fistula, so he was never seen until 2023, where his graft started to fail, and he was referred to our vascular access clinic so we could see if his fistula is still okay to be used as he transitions to dialysis. So I still remember the day this gentleman came to our clinic, and my surgeon, myself, and our vascular access nurse, Nikki, were kind of looking at each other going, oh my God, this man has had this fistula for 20 years, and it was a big fistula. It looked like a high flow fistula. And what has this done to his heart? So we looked at him. He looked well. He had no symptoms of heart failure, no restrictions in terms of his physical functioning and exercise tolerance. Fistula looked great. So he started dialysis, no problems because his fistula was working well. So didn't have to get a new fistula created. And he was interested in home hemo, transitioned to home hemo very easily. Fistula was easy to cannulate, so he was trained quickly, and he's been on home hemodialysis. We decided to do some cardiac investigations. We ordered an echo and a MIBI. His echo, there was no obvious overt heart failure, evidence of heart failure. He had some concentric hypertrophy, but a history of hypertension. His global longitudinal strain was normal pulmonary pressures, and his MIBI was normal. So this sort of illustrates the difficulty in deciding what to do with these patients, because if you look at this patient up front in this history, most people would say, like gated, why should this fistula be in place for so long? But if you look at it the other end, in this particular patient, he didn't really have any complications, and having the fistula in place helped him transition to hemodialysis seamlessly and quickly. So it does illustrate the difficulty it comes. But I think it is really important for us to remember that having these fistulas in place does present huge cardiovascular risks in terms of the pathophysiology that occurs. And this is very complicated. So I'm going to give the slides now to Dr. Borkum, who has really looked into this and is going to describe the pathophysiology with regards to this issue.
Thank you very much. So I'll just go through this fairly quickly because I'm sure we're all aware cardiovascular disease is the leading cause of mortality in our patients. And these risks increase as the kidney function worsens. We know that there's a number of traditional risk factors like hypertension and diabetes, but similarly, all the non-traditional risk factors come into play as the kidney functions worsen. So anemia, oxidative stress, fluid overload, etc. And also, as you can see in the top corner in purple, as patients progress to kidney failure, non-atherosclerotic events such as arrhythmia and non-traditional causes contribute more to the cardiovascular events and diseases that we see. So interestingly, echocardiogram-based studies in prospective cohorts have shown post-transplant that there's an improvement in some elements of structural heart disease. So LV mass, left atrial volume, and ejection fraction as early as 12 to 24 months post-transplantation. But even though we know that kidney transplant does somewhat reduce cardiovascular disease risk compared with staying on dialysis, kidney transplant recipients still experience a higher rate of cardiovascular disease outcomes and death compared with the general population due to the traditional risk factors, but further a milieu of non-traditional risk factors that come into play, such as inflammation and immunosuppression. And as you see in the last point there, which we're going to touch on some more, is the persistent dialysis access. So why are AVFs possibly associated with increased cardiovascular risk? Obviously not in all cases. So as you can see in the figure, AV access bypasses the systemic capillaries and the associated vascular resistance. This causes increased venous return to the heart, therefore contributing to increased cardiac output, leading to or exacerbating left ventricular hypertrophy, and over time, all the sequelae we know and love, so heart failure, pulmonary hypertension, and heart valve dysfunction. And importantly, the risk of death and cardiovascular events is higher in people with progression of left ventricular hypertrophy. And similarly, right heart dysfunction also has been shown to worsen after AVF creation and is also associated with increased mortality. To the topic of fistula flow, it's also been suggested that higher flow fistulas could further worsen cardiac structural changes. So left ventricular mass index, which is the left ventricular mass index for body surface area, essentially refers to inappropriately thicker heart muscle for the patient size. So as you can see in the picture, the heart muscle evolves with time. Studies such as this one shows that a higher left ventricular mass index was seen, and this was as early as 6 weeks after AVF surgery in those with higher AVF blood flows. So although consensus is lacking, AVF flow is generally agreed upon to be deemed excessive when signs of heart failure develop or when flow surpasses 1,500 to 2,000 mils per minute. So there's no perfect vascular access. So we acknowledge these possible cardiovascular risks, but we favor AVFs generally for reliability, longevity, stability, bearing in mind that the alternative is a permanent central line, which can have significant complications and harmful outcomes, including bloodstream metastatic infections. So as Merecedeh said, the question is, in those with a functioning but unused AVF after transplant, whether ligation of this unused fistula could mitigate adverse cardiovascular structural changes and risk. And unfortunately, there's limited data and no guidelines as a result existing for what to do with AVFs post-transplant. And as whoever of you attended CSN, this has become a topic of interest and debate. So I'll discuss some available evidence. So this is a fairly recent observational cohort study from Scotland, which I'll just briefly mention. It examined 1,330 patients who received a kidney transplant between 2010 and 2020. And they did models looking for associations, so factors that associated with de novo or new heart failure. And they used echo-based criteria. So they found that a presence of an AVF was associated with de novo heart failure, as well as with the composite adverse cardiovascular outcomes. So this is an observational study, so it can't directly determine causality, but it does add further food for thought on the possible deleterious effects of unused fistulas post-transplant. There's been other few small echo-based studies that have tried to answer the question of vascular access post-transplant with mixed results. But this is a great, fairly small, but randomized controlled trial in 2019 of 54 patients more than 12 months after transplant with a stable graft function. And they used cardiac MRI, not echo, to assess the effect of elective AVF ligation on left ventricular mass. So at 6 months, they found that ligation resulted in a significant mean decrease of left ventricular mass of 22.1 grams. And this compared to an increase of 1.2 grams in the control group. But there was no association between the location of the AVF or brachial artery flow and structural changes, and no difference in the effect size across a range of flows examined. But because this was a small sample size, it wasn't really powered for these subgroups. So analyses validity was limited. And this is a follow-up study of the one I just mentioned. So they followed a subgroup of 17 patients from the initial study who had the AVF ligation, and they did a repeat cardiac MRI after about 5 years, and they found a statistically significant reduction in LV mass and LV mass index that persisted over the long term. So long-term benefits continued, which was very encouraging to see, but once again, a very small sample size. So just a quick word on the topic of cardiac MRI. It's been increasingly used in studies in this population and has become somewhat of a gold standard. It allows for measuring many cardiac structural and functional parameters, is more reproducible than echo, which is obviously more widely available, cheaper, and easier to get a date for. And this is especially true in the case of end-stage kidney disease with regard to reliability and reproducibility, because we know a lot of our dialysis patients have fluid overload, and their hemodynamics could interfere with the echocardiogram results. So MRIs are very useful, provide extra information on other elements like myocardial scar, interstitial fibrosis, coronary artery flow. Therefore, they offer a wealth of information, and they're increasingly used as a result in trials. So as we said, this area has garnered a lot of interest internationally as well. And this is a protocol which Rupert brought to our attention, looking, it's a feasibility study that's planned in the UK. And the authors based this study on the hypothesis that AVF ligation would improve cardiorespiratory fitness, thereby increasing patient activity levels and improving quality of life. So it will be interesting to see once the study eventually concludes what their results are. We're also undergoing very early preliminary discussions to plan a possible observational prospective multi-center cohort study, recruiting locally and in collaboration with a team at Leicester. The proposed study would involve patients that are active on the kidney transplant waiting list, and they would undergo, we would target those patients who expected to undergo a transplant within about 6 months, and they would undergo a baseline cardiac MRI and then serial cardiac MRIs at time points with a parallel chart and AVF review. So obviously we'd include only those patients with a fistula. And then on the serial MRIs, we'd be able to trend cardiac structural changes pre and post transplant. And then similarly, we'd be tracking their fistula and compare our findings between higher and lower flow subgroups, with the hypothesis that in these patients post-transplant, in those with a patent high flow fistula, more adverse cardiac structural changes will be seen on serial MRI. And I'll hand back over to Merecedeh to summarize.
Thank you, Megan. Okay, so In summary, I think we've touched on a number of things, but I think we've stressed the importance of timing of AV access planning and how this continues to be challenging. We need better timelines for patient-related outcomes and the optimal use of scarce resources such as OR time. We now have some risk-based thresholds that we can use to help us with vascular access planning. But just as Dr. Major pointed out, it is very important for us to validate this and to continue to use our clinical judgment. We cannot use these thresholds as the end-all and be-all to make these decisions. And then finally, we've heard about the cardiovascular implications in patients who do have fistulas long-term. So it's important to mitigate these associated cardiovascular risks and do further work using modern cardiac imaging techniques, using MRI, to determine what's the best management strategies for these group of patients who do have fistulas post-transplantation. So thank you so much for your attention, and I think we'll open it up to questions now.
Yeah, thanks for an amazing overview of vascular access in 2024 and where we are and questions and ways to improve care. We have about 7 minutes for questions. Kevin's asking, is there enough confidence in the 2-year KFRE to use it as a sole measure to rank order your local VA wait list? I think that's the great question, Kevin. I think that's part of what I believe is what, Merecedeh, you're going to try and discern, right? Like, what is that threshold?
Yeah, I mean, I think that what we were trying to stress is that is this showing that it's extremely important information and can help us. But I really believe in what Rup was mentioning, that we do still need to make sure that we do proper clinical assessment of the patients and look at the rate of decline and other things. So I think as we study it more, we'll learn more, but I don't think at this point we're at a place that we can use it as the sole indicator of when we should go forward with either planning or creation, more importantly. I don't know if Rupert or Atiq want to comment as well.
I'll just add, yeah, I think it's an improvement on EGFR, as we've seen with that, but it's not going to replace it. I think, however complex algorithms are, whether we in the future look at machine learning or anything like that, I think ultimately there's still going to be clinical judgment involved in this sort of decision making. I think that the factor we also need to think about looking at is risk factors for a fistula formation being successful the first time. And I think most of that will be around other factors like diabetes and associated factors, because you then need a longer lead time to create the access.
Yeah, I guess, I mean, one of the questions is, if you've got 3 people and 1 OR spot and the same GFR, and people have a KFRE of 60, 40, and 30, might you, with the 1 OR spot, decide on the higher one? I mean, I think that that's part of what the project is, right? But in the interim, it wouldn't be crazy to think like that. But I think it's not yet ready for prime time, which I think is the value of asking the question. Claire is asking, how do we address patient factors in incidence AVF rates? Can we look at patients who may have been referred at appropriate timeline but decline or defer surgical dates? We observe this, and we'll be able to look at education, other patient factors. I think it's a different question, Claire, but I think reasons for decline is, I don't know how well we capture that, but I suppose that's something that could be a program of work to optimize that group. But
yeah, it's actually been brought up to attention, and Melanie just brought it up, Melanie Brown from Fraser. And so we're going to actually start to look at that a bit more, like, why was it refused? Have we readdressed it? What was the concern? So we're going to probably look at that a little bit more in terms of why, and see if we can address it.
Great. Another question? I think that's it. Yeah, no, I think in terms of the transplant program of work, I imagine the transplanters have been also asking this question. So across both the UK and BC, is there sort of a working group that you guys have established?
Are you asking the transplanters, or are you asking?
No, you guys.
Oh, I see. Yes. I mean, when I started to sort of look at this and go, get worried, I did approach our transplant physicians, and that's where we said, let's start actually doing an implementation study where let's start the clinic and actually start to see these patients post, so we can actually look at any heart failure symptoms. And then I was very happy to hear that Rup's group as well is interested. So I think that if we can collaborate and have a larger number and actually do the proper assessment in terms of we're going to do obviously clinical assessment of questionnaire, walk test, but that imaging, that's what's been very difficult, because echo parameters have always not been very definitive. And so I think working with our UK colleagues and looking at the MRI, so it's going to be very, very helpful.
Great. 2 minutes to the end of it. So any other comments that you guys would like to make? I think it's really, go ahead.
Another question in the chat.
Oh, another one. Does use of high flow fistula need any attention or surgical repair to prevent cardiac risk? I think you sort of answered, like, we don't know because it's variable.
Exactly, like revising it to making it less high flow. I think that's maybe what the question is. And there is no surgeries that actually guarantee that that's going to work. So especially in the patient who's we're not using the fistula, you're not going to expose them to surgery to try to reduce the flow. If you're going to do surgery, you'll probably take it down, right? Because there's no guarantee the flow will go down.
But I think it's also quite fascinating that you've got the case that you showed. Like, you can have high flow and nothing happen to your heart. So I think it may be some interesting other problem that we're missing, because, and I also wonder if one looks at, size and flow, because, little ladies that are 36 kilos with a 1 liter flow rate might be just as badly off as people. So I think that sophistication is probably needing a little bit more understanding.
And I think if I could just add, I think often from a patient perspective, the thing that prompts them to ask about it is the actual appearance. So if they're using the fistula or transplanted, it's the fistula's getting bigger, and I don't wear short sleeve t-shirts or shirts any longer because I just don't like the look of it. Is often the thing that prompts us to discuss it in clinic as to what to do. And I think we underestimate actually the impact of that for patients, and the actual appearance of the fistula.
Right.
Yeah.
Well, yeah, no, I think it's really interesting. And I guess, to summarize the summary, again, thank all of you, not just for the presentation, but for all the work and thought that's gone into this, because I know it's perplexing, and that kind of attention to detail to make it better for the individual patients as well as for the system. And I think this is a great example of that, right? We're trying to make it better for the individuals and also better for the system, so we get the right resources allocated in the right place. So thank you very much, and we look forward to the update. So happy Friday, everybody, and thank you, Rup, for joining on your Friday evening. And all of you, happy longest day of the year.
Thank you.
Thank you. Thank you.